Hi, my name is Fernando Triviño. My topic about is the right-finding antithrombotic therapy for atrial fibrillation and acute coronary syndrome or PCE. The first definition. The definition is acute coronary syndrome is a term of prospective operation at the time of the patient's initial presentation, which allows a therapeutic behavior and a definite diagnosis. Applied in medicine. Thrombolysis causes an immediate procoagulant response after finishing the infusion, with the consequent paradoxical thrombotic effect. The trigger appears to be the exposure and thrombin contained in the partially releases and thrombus that activate the platelet and the intercoagulation cascade. Now a video.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy, with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 mg dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 mg dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 mg dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Okay, now, issue application in Ecuador. Until recently, interventional cardiologists were reluctant to perform on coronary catheterization in fully anticoagulated patients. The radial approach and the daily problem of patients with AF with change in anticoagulant therapy has led to more frequent use of PCE in patients in one anticoagulation in continuing without the use of bridging therapy with heparin, given the increase of thromboembolic and hemorrhagic risk that this entails. Now, pros and cons. This type of presentation is frequent in this population due to hemodynamic deterioration caused by rapid AF itself, anemia, or even coronary embolism. Invasive strategies will require a change in the antithrombotic medication regimen, that is a longer duration of the dual combined antiplatelet therapy, which is always associated with a higher incidence of hemorrhage. After an individualized examination of each case, a conservative strategy for certain patients can be evaluated. Now a video.
Pros and cons of medication versus ablation for atrial fibrillation. Compare two options for atrial fibrillation treatment to improve your quality of life. If you're one of the 2.7 million Americans who live with atrial fibrillation, a tricky-to-treat condition that causes your heart to beat irregularly, you may be unsure how to treat it. Symptoms of atrial fibrillation, also called AFib, can be debilitating. They may include palpitations, shortness of breath, fatigue, and weakness. But trying to reduce these symptoms through drugs that control the abnormal heartbeat, called antiarrhythmic drugs, can come with serious side effects. Another treatment option is catheter ablation. During ablation, the abnormal heart tissue is destroyed by burning or freezing it. Ablation has a greater chance of reducing and even eliminating your symptoms and making you feel better. But the procedure is invasive, expensive, and not right for everybody. How do you choose between the two? Having a clear sense of the risks and benefits for both can help. Neither antiarrhythmic drugs nor catheter ablation decrease the risk of stroke. These treatments are designed to control symptoms caused by the abnormal heart rhythm. Walid Saliba, MD, a cardiologist who treats atrial fibrillation at the Cleveland Clinic in Ohio, says, "The aim of any treatment for atrial fibrillation is to reduce the burden of the arrhythmia, the frequency, impact, and symptoms, and improve quality of life. Treatments are more effective and better understood than ever, say experts." Guidelines issued in March 2014 by the American Heart Association, the American College of Cardiology, and the Heart Rhythm Society recommend ablation as a first-line therapy for atrial fibrillation. And research continues. A large trial called Cabana is underway, sponsored by the National Institutes of Health, to provide even more answers regarding the use antiarrhythmic medication versus ablation. Medications can stabilize the heart muscle tissue and help return the heart to its normal rhythm, notes the American Heart Association. Some people take the meds every day, while others take them just when they feel palpitations. These drugs work well for some people, but not all. How do the pros and cons compare for now? Here's a look. Pros of antiarrhythmic drugs for atrial fibrillation. Many options. Your doctor will recommend certain drugs based on your age, your health, and the severity of your symptoms. If there's underlying heart disease, you may be restricted in what medication you can take, says Dr. Saliba. Cost-effective medication is typically less expensive than procedures like ablation, in the short term. But if your atrial fibrillation results in repeated hospital visits and changes in your meds to better manage your symptoms, the cumulative costs may even out over time. Non-invasive. It's easier to take a pill than to undergo surgery. Patients who are squeamish about surgical procedures and more comfortable taking a less aggressive approach to controlling their symptoms typically start with medication. Moderate success rate. Success rates average around 50% overall. Research shows that with medication there's a good 40 to 60% maintenance of normal rhythm at 1 year, says Saliba. And that's acceptable to some patients. Cons of antiarrhythmic medication: dangerous side effects and interactions. Nausea, dizziness, diarrhea, breathing problems, and swelling are some of the side effects associated with antiarrhythmic drugs. Other side effects are more serious. The drug amiodarone, cordrone.
O- Okay, now, conclusion. Conclusion: a patient with AF treated with Zen are a high-risk population with high comorbidity. In recent years, several strategies have been proposed, supported by expert consensus, documented, made, and reducing the risk of hemorrhage without increasing the risk on thrombotic. Now a video.
Hi, my name is Dr. Fu Chi-yong. I am a physician researcher and a PhD candidate in Monash University, Malaysia. I would like to share with you our research study investigating the association between the delay in coronary intervention for myocardial infarction and the risk of mortality and other related adverse outcomes. Myocardial infarction is a medical emergency in which sudden occlusion of the coronary artery causes a disruption of the blood circulation to the heart. As a result, heart cells die and their functions are lost. Reperfusion therapy is an important part of the treatment for myocardial infarction. Primary percutaneous coronary intervention, in short, PCI, is the preferred mode of reperfusion therapy when available. Timeliness of delivering this life-saving treatment is an important quality dimension of many modern healthcare systems today. One widely used measure of reperfusion timeliness is the door to balloon time. The door to balloon time is referred to as the delay in between a patient's arrival at a PCI-capable hospital to the moment of the balloon inflations that reopens the occluded artery. Door to balloon time of greater than 90 minutes is generally considered a modifiable system delay and therefore an important target for quality improvement efforts. Over the past decades, there has been significant improvement in the door to balloon time across many healthcare systems. However, recent studies have shown that despite this improvement, the overall mortality of those receiving the procedures remain unchanged. This raises questions of whether door to balloon time reduction is still a worthwhile quality effort. Motivated by these recent controversies and the lack of a systematic assessment on this topic, we conducted this study. In this study, we review literature sourced from a wide range of databases. We look for prospective observational studies that have investigated the relation between door to balloon time and clinical outcomes. Through our systematic searching, we found 32 studies involving nearly 300,000 patients that provided adequate data for further analysis. In the main analysis, we found that door to balloon delay exceeding 90 minutes was associated with a 50% increase in the odds of mortality. This time outcome relation appears to follow an exponential-like nonlinear pattern. This nonlinear pattern implies that the impact of door to balloon time reduction is likely to be more significant when the baseline delay is longer. We also found that longer pre-hospital delay changes this time outcome relation. Specifically, those presented late showed no beneficial effect even if the door to balloon time was short. This finding signifies that the consideration of reperfusion timeliness should be extended beyond the hospital door to optimizing the pre-hospital processes. In conclusion, longer door to balloon time in coronary intervention for myocardial infarction is related to higher risk of adverse outcomes. Minimizing this delay should remain an important part of the quality improvement effort. This is especially important in settings where door to balloon delay remains significant. Because pre-hospital delays modify the effect of door to balloon time on outcomes, improving this segment of the delay chain should be further emphasized.
Thanks for watching.